Assalamualaikum.
Hello, viewers.
Hello. Sir.
Walaikum salam.
I, Dr. Kazi Menas, would like to welcome and thanks everyone for joining us in the 27th episode of our discussion session arranged by Basic Dental School, Bond. Today, we will be covering our topic on digitization of occlusion. We will take a 30 seconds of break so that we can share live to our Facebook page as well as our Facebook wall. I would like to request everyone welcome back again. We are very honored to have some valuable guests today here. Thank you for pursuing your time for your day-to-day life. We are very much honored to have Professor A.K.M. Azizul sir, Professor, retired Department of Prosthodontics, Dhaka Dental College and Hospital as our chairperson. We are very grateful to announce that we have our speaker, Professor Prafulla Thumati, PhD, Professor and Head of Department of Orofacial Pain, RRDC, Bengaluru, India. Thanks for joining us, sir. Dear
It's my pleasure.
Yes, Dr. Mosharraf Khondokar, Director, Dental Health and DGHS, Haque. Our respected panel experts are Professor Mahbubur Rahman, Chairman, Department of Prosthodontics, BSMMU, Professor Khushida Tanzir, Professor and Head of Department, Prosthodontics, Dental College. Dr. Anupam, BDS, MS, Prosthodontics, Associate Professor, Department of Periodontology and Oral Pathology, Dhaka Dental College. Now, I'd like to request our chairperson to give his inaugural speech. Please, sir.
Show your face.
Dr. Ajit, sir.
Okay.
I'd like to request
Say
you to give
that,
your
Aziz,
welcome speech.
Okay. Yes, sir. Yes. First of all, I would like to introduce our speaker. First of all, I would like to introduce our speaker, Honorable Professor Prafulla Thumati, to the listener and viewer. Professor Prafulla is now working as a professor and HOD of Orofacial Pain Clinic, Raja Rajeshwari Dental College, Rajiv Gandhi University of Health Science, Bengaluru, India. President, Indian Prosthodontics Society, 2016-2017. Professor Thumati is our old friend from 2010. He has come to Bangladesh for several times. Different us. Sometimes he used to come as a trainer in a foreign training. Sometimes he used to come as a speaker in a seminar organized by the different professional organizations like Aesthetic Body and Oral Health Foundations and other like this one. Professor Thumati is a fellow of the famous digital oculologist, occlusal specialist, Robert Christian Coachman, and he is one of the famous occlusal specialists in Southeast Asia. Today, Prafulla Thumati will present in our program is new topics, which is very, very important nowadays. It is digitization of occlusion. Digitization of occlusion. Now I like to invite Professor Prafulla to present the presentation.
Thank you, Aziz Bhai. Thank you, Aziz Bhai, for those good words. Roshan, I need to share the screen. Going to screen sharing. Aziz Bhai, you're able to see the screen?
Yes.
So, namaste to all dear Bangladesh dental medicine graduates. Namaste to you all from India. My all dear family of Bangladesh, namaste to you all from India. I always go with this slide. I honor the place in you in which the entire universe dwells. I honor the place in you which is of love, of truth, of light, and of peace. When you are in that place in you, and I am in that place in me, we're all one. Namaste. This is the age-old signage of Namaste. Wherever we are on earth, we get connected by folding hands, pressing the fingers together, and saying Namaste. Namaste to you all from India. I'm indebted to my mother institution, Government Dental College, Bangalore, and Bapuji Dental College, Hungary, my late parents, and my lovely family for all their support. And we are talking about digitization of occlusion today. As per Glossary of Prosthodontics 9, you can say occlusion is basically the act of mandibular teeth coming in contact with maxillary teeth. Fine? So the act of process of closure or of being closed or shut off, the static relationship between the incising or masticating surfaces of the maxillary or mandibular teeth of two canaloids, which we all use the words like articulation, centric occlusion, components of occlusion, eccentric occlusion, line of occlusion, linear occlusion, monoplane occlusion, pathogenic occlusions, spherical form of occlusion, XYZ names, right? All of us, like I'm into prosthodontics for the last 30 years. We talk about occlusion. I love Boucher. I tell his definition. I love Dawson. I tell his definition. I love Aziz. I tell his definition. I love Anupam Poddar. I love his definition. That is subjective, my dear friends. Like Ramsey and Ash or Dawson or Okeson, XYZ. But when we talk about occlusion, this is the best article I have found, The Gateway to Success about occlusion. And it says, success of our clinical procedures is not a single day entity, but instead survival on a long-term basis. The clinical longevity of our work is dependent on so many factors, and we have a closer look, all these ultimately depend on the occlusion stability. My dear friends, in this article, we are talking about dentistry. I am talking about dental medicine. Today, we have enough proof to say that occlusal stability is very, very critical for the stability of the musculoskeletal system. Mother Nature, call it as Krishna, you call it as Allah, XYZ call it as Jesus, doesn't matter. I call it as Mother Nature. Mother Nature created, one of the slides in later level, you'll see how Mother Nature has created us, okay? So talking about occlusion, the different concepts are there, frictional period from 1900, mathematical period from 1900 to 1930, and factual period 1930 to the present date. This is all subjective science. Oh, Prafulla, this is true. Oh, Aziz Seki is saying it is true. Anupam is saying it is true. That is not, my dear friends, is science. That is subjective science. We are going to listen and discuss about objective science today. Right? We all have heard about balanced occlusion, which is basically meant for removal prosthetic work, and then group function, and mutually protected occlusion, organized or organic occlusion. I will share this entire PPT to your group. You always can go through. And then came the canine parietal occlusion. This is the best concept for the humankind. Canine parietal occlusion is there, from 1990. Amazing work done by D. Amico, 1958 onwards, and even Shaw in 1924. They all talked about it. Even today, with advanced technology, canine protected occlusion and occlusion. What is the difference between subjective and objective science? That's what we are going to discuss about. In subjective science, my professor Dr. Aziz said this. I heard the speaker, Dr. Prof, he said this, subjective science. Wherein objective science, we are going to discuss about objectivity of it with values, in numerical values, right? So currently we are talking about biologic or physiologic occlusion. It is defined as an occlusion in which a functional equilibrium or state of homeostasis exists between all tissues of masticatory system. The biologic process and local environmental factors are in balance. A physiologic occlusion can present as a number of variations structurally, but in a given individual represents an acceptable functional occlusal relationship. The mere fact that a patient does not exhibit the features to be expected from a dentist's own concept of occlusal organization is not in itself a mandate to treat that occlusion. New information and insights require continued analysis of our concepts, which are likely to change over time. This trend, coupled with our knowledge of human anatomical and functional variability and adaptation, requires that we avoid any unalterable dogma regarding any one concept or therapeutic approach to the occlusion. Please understand this next paragraph. I and you should never have a rigid approach. We should be ready to accept anything which comes in new with a scientific background. That's what it means. So with that background, with the advanced science, we are talking about neural occlusion, which depends on neural response, maybe afferent nociceptive or proprioception, processing via CNS, central nervous system, efferent muscular responses, and occlusion. And neural occlusion classification goes as per, thanks to the inputs from Dr. Nick Ionis and Dr. Piper. We are putting into type A, type B, type C, depending on the status of the temporomandibular joint. And thanks to godsend concept by Dr. Robert Custine, intercuspal theory, ICAGD. Sorry, this is C, not G. ICAGD, intercuspal, okay? Immediate canine anterior guidance development. It is not G, it is C. Immediate canine anterior guidance development. The occlusion is determined by the habitual fit of the most teeth contact. Let's come into the statement of Charles Darwin. All of we know, Darwin always, we all believe, as children we studied the survival of the fittest. But look at the as it gets aged. It is not the strongest of the species that survives, or the most intelligent that survives. It is the one that is the most adaptable to the change who is going to survive. That is what it means, my dear friends. Let's see what is that adaptability we all should go through. That is about objectivity. We all know how technology is changing dentistry in every walk of life. Whether it's medicine or dentistry or anywhere, there's a lot of change, right? So the digital dentistry revolution is transforming the every aspect of our world, is also impacting dentistry and medicine in a multitude of ways, from electronic record keeping and data analysis to new diagnostic tools, novel prevention methods, and revolutionary treatment options. The future is wide open, my dear friends. We know digital dentistry is taken part in every walk of dental medicine, right? Whether you want to do restorative dentistry or implants or oral medicine and diagnostics, or every walk of life, it is taken over. So whatever the occlusion and stomatognostic system, let's see in what way the restorative dentistry will be benefited. So we are going to discuss about occlusion and stomatognostic system, how we are benefited by the advanced technology. Mother Nature, you and me might call God, maybe Krishna, Rama, or Allah, or Jesus. I, I love to use the word Mother Nature. Mother Nature created the skeleton when she created the human beings. Of course, she didn't like it. Nobody can love the skeleton, right? So that's when she stuffed the body with internal organs, and like any mother, we all should love the women for their sacrifices. Mother Nature loved the creation what she did, and to protect her child, she covered the body outside with skin and inside with mucosa. And then she said, "My child is so cute. Let me talk to my child." So that's when I hope you are able to see. As a prosthodontist, I have put a geriatric patient's edentulous mouth, and after giving a remedial prosthodontics, complete denture, upper and lower complete denture, there is a slide. What is the meaning of it? So Mother Nature, the entire human body, she created all the branches of medicine, whether you want urology or cardiology or neurosciences. Then she realized she has made a mistake. I'm talking about Mother Nature, God. Then she realized, all of us, we do mistakes, right? Like that even God did a mistake. She never created. She realized when she created those beautiful 32 pearls, 32 teeth, them in and connected them right from head to toes, my dear friends. We are not just specialists, we are super specialists at BDS level itself. Let's be proud. Mother Nature gave that opportunity to us. So who else can tackle these problems which are concerned with the teeth? As you go down the presentation, you realize what I'm talking about. So now coming to the presentation about the biometric tools. We all use the word TMJ, but we use it in terms of teeth, muscle, and joints. Believe me, if you see the CBT and MRI image on right side, we have documented proof today. Even I have pre and post treatment. Even a resolved mandible, condyle, can be grown back if you give a good environment. Mother Nature has gifted us with genetic information. Some bad times like this coronavirus pandemic, we all are struggling. If you create a normal environment, the things will go back to normalcy. Even condyle reserve will grow back because of the genetic information. That is a gift of Mother Nature, of the mother to her offspring. So these are the tools we have. T-scan for digitizing occlusion, JVA for digitizing the temporal joint, EMG for digitizing the muscles, not only of masticated muscles, we do have 8-channel EMG wherein suprahead and infrahead muscles we do record, and then a joint tracker to track the movement of the mandible. Then, of course, we have a TENS gadget tool to help us in the therapy, and CBCT or CT and MRI in imaging the stomatognathing system. These are the tools which we are going to talk today. This is how they look. T-scan sensor with the hardware, amplifier box which can the biometric tools, joint tracker, JVA, and EMG. So let's talk about in brief for a few minutes, couple of slides about these tools. Then I will take you through a couple of cases, treated cases. What is this T-scan is all about? T-scan is as simple as this: a sensor connected in the hardware, connected to the software by USB port into the computer. This is one of my patient slide. We just ask the patient to bite onto this sensor, my dear friends. The moment you ask them, if you recruit today, we have synchronized T-scan software with biological software. We can recruit masticatory muscles when you are digitizing occlusion together. That's the best thing all about these tools. The moment the patient bites into this electronic sensor, immediately it captures the data and sends it to the software, and this is how the window is thrown up to us. And today, if you have an intraoral scanner, advanced technology. I have my own intraoral scanner in my clinic. I scan the patient's teeth and the HTL file. I import it into my T-scan software. You don't have any subjectivity. It is purely objectivity. You have the patient's own teeth in your touch form, and you know where the problem is. Okay? And to talk about the myths of occlusion, this is what is taught from last 100 years, my dear friends. If you see the photograph here, oh, this is the biggest mark. Prafulla will tell Aziz bhai it's going this. Aziz bhai will tell hey, Prafulla it's going this. Because this is the biggest mark. This is highest force. This is very pretty small. Don't do that. Right? Do we have any meaning for that, my dear friends? Does it have any quantifying data about the force and the time? No way. Right? Let it be even Dawson, Dawson or Wilkinson. We cannot quantify with the current subjective data from articulating paper marks or from paste or spray, whatever the means we are using. So it's a myth, right? You cannot force and time can be determined by paper mark appearance. There's no way. You cannot identify, right? Only technology available today in the world is the T-scan data. Conflict of interest. I am not paid for this talk by any companies. It's purely love and affection of my dear Bangladeshi dental colleagues I'm speaking, okay? I'm not speaking for any gadgets here. The Dawson principle is very good occlusion is dots at the back and lines in the front. Patient is not comfortable. You take your T scan and measure. I see this is one patient's 88% and 12% on the right. Picture perfect occlusion visually for human eyes. But in a dynamic way, you measure with a T scan, you see 88 on left, 12 on right. That's absolutely very bad, isn't it? Your eyes and my eyes cannot recognize this. One more case, dots at the back, lines in the front. What do you see? 77.9% on the left, 22.1% on the right. This is one more patient of mine. Actually, this patient is a professor of maxillofacial surgery. She was not comfortable. When I measured, this is what the situation is. So, how do you recognize that, my dear friends? Thanks to all these engineering tools who have come up with these technologies, we are able to recognize the issues and help our fellow human beings. It is time we change our mindset, open our minds to the new technology. To talk about digital impressions, just for a minute, maybe 2 or 3 slides. This is an intraoral scanner. I use an intraoral scanner for case train. I'm just trying to forward it. As you scan, you get a DICOM file in your system. Okay? Yeah, this is my tooth prep, but for my TMD cases, I scan the entire arches, both upper and lower. That is a DICOM file. While saving, you save it as STL file. This is how simple it is. Just take it's like your video camera, you're making a video. That's how it destroys the teeth and the gums. So, so this is how it looks. Of course, this case was a prosthodontic case where I was making 3 individual crowns. That's how the prep looks like. Look at that, all my dear friends, look at that. Before even I send it to the lab, I know there is a kind of clearance I have, how my preparation is. If you want, you can always modify and redo the scanning. Lab guy may not tell us, sir, there is no clearance. This is all about disguising or intraoral scanning. And now, with that HTML file, how do I use it for occlusal purpose using T-scan? This is the T-scan software. Like how we take case history, we feed the feedback, and wherever the HTML file is, browse it and incorporate. Browse, and then the data is, once you say the data, this is the icon. If you have an STL file of a patient, this is the impression, it gets highlighted. Go ahead.
Making trying to see what is the actual making trying to see that into the see.
Sir, I don't know. So this is how we incorporate digital impression or a 3D model into our software. And he is my mentor, he is my contemporary, a prosthodontist, Dr. Robert Custine from Boston, USA. He spent 4 decades of his life about objective science. He's the one who has come up with this concept, and I owe all this knowledge of mine to himself. He talked about occluding time and discluding time. The time we take to occlude the lower teeth, getting into occlusion with the upper teeth. Neurophysiologically, it should take less than zero point 0.2 seconds, and that's what it's all about. You need to refine if there's any problem there. And disclusion time is the time taken for you to open your mouth or right to left or right or forward. And that should take neurophysiologically, not as per my dictum or your dictum. It should take less than 0.5 seconds. That's a neurophysiology, that is a body requirement, right? If there's any problem, my dear friends, disclosure time is a very important word. Please keep it in your mind. If it is more than 0.5 seconds, a lot of people get into temporomandibular dysfunction. You will understand as we go on. Now I'm talking about neurophysiology. What is this neurophysiology is all about? It is how Mother Nature created us and what is normal. Neuromuscular physiology. If a person has something more than 0.5 seconds disclusion time, these 2 slides are of a microvascular surgeon who had migraines for about 38 years. When he came in, this is how his masticatory muscles were working. 2 visits, it just calibrated using this technology, and this is how his muscles are working. Look at this picture and look at this picture, my dear friends. This is the neurophysiology we are talking about. Let's see in the next 2 or 3 slides what we are trying to convey the message. Of course, all of us, we need to take a step back because all our teachers in medical school and dental school said, oh, you're going to be a dentist, so know more. Just study head and neck without brain. My dear friends, to treat a human being, we should know all this. So at least as dental medicine graduates, let's understand the kingpin of cranial nerve, the trigeminal nerve, and then the muscles involved. And this is what the neurophysiology I'm talking about. You know the beauty of trigeminal, the entire body, you take any system, cardiac, respiratory, or you take any system, it is supplied by one nerve. But look at the masticatory system, what you're going to see in the next 2 slides. Masticatory system is the only system in the entire human body which has a dedicated supply of 7 cranial nerves out of 12. Basically, 9 cranial nerves are involved, but 7 cranial nerves are dedicated, not even the heart, not even the kidney, not even your liver. Why? Because at a given moment you eat a soft food like cake, the next moment you try to bite onto your bone piece, right? But Mother Nature never wanted a child to chew her own cheek or tongue or lips. That's why this dedicated system. And what are the masticatory muscles separated by? Trigeminal nerve, right? So trigeminal nerve between the rest of the body and trigeminal nerve. Trigeminal nerve supplies the masticatory muscles and of course other parts of the stomatognathing system. But look at that arrow going in. It goes through trigeminal motor nucleus and directly communicates with the reticular formation. The reticular formation. And the moment it reaches the reticular formation, What is the point that I'm driving? The moment there is a response in your central nervous system in the brain, and you know you're touching your hand, efferent and afferent responses. But when it comes to masticatory muscles, there are no synaptic junctions, my dear friends. This is what I'm trying to show you in this slide. Absolutely, there are no synaptic junctions, there are no signal lights. Directly, the message goes in because Mother Nature doesn't want you to chew your own tongue. It says, okay, open your mouth, close your mouth. So that's what is the problem. The propriosensitive and mechanoreceptors in the posterior teeth, premolars to molars, are supplied by these nerves, wherein the moment you clutch, there is a response, and if you're taking more than 0.5 seconds for any of your excursive movements, the muscles go into hyperactivity and you will have lactic acid buildup, which leads to ischemic changes in the muscle. That's what leads to temperamental dysfunction or any problems to do with clenching, bracing, XYZ. Okay? That's the neurophysiology which is involved stomatognathia system, and OS, we are the best people to address it, right? A neurologist or a neurosurgeon cannot handle it. Only a graduate from dental medicine can handle it, masticator system. And the other point I want to convey today is referred pain we have understood, right? But when you talk about the cranial nerves, swallowing is meditated by the parasympathetic nervous system. When all the 12 cranial nerves they originate and try to exit out of the brain, the seventh cranial nerve is accompanied by cranial 3, 9, and 10, and they are supplied to all these internal organs. Cranial nerve 3, 9, and 10, they supply all these internal organs, my dear friends. You have a problem on teeth, the symptom could be anywhere in these internal organs. Please keep that in mind. So we need to go back and refresh our knowledge about anatomy and physiology so that we'll be in a better position to help our fellow human beings. For example, Mother Nature has given 32 teeth. What is the purpose? Every gulp we take, we are supposed to chew it for 32 times, my friends. 50 to 60% of digestion happens in the mouth when you are masticating. If you don't do that, swallowed in, that's when you have a problem in the stomach called IBS, irritable bowel syndrome. I'm just giving one example because I have a lot of other things to show when we treat cases using this technology. Okay, this is the reason you need to understand the advanced science. Robert Custine gave this concept of long disclusion time and measurable immediate posterior exclusion. If you reduce the disclusion time to less than 0.5 seconds, you use less muscle fibers. Quickly, the byproduct lactic acid is used up, and so that you are more comfortable. Okay? So let's see. There is a notice. Let's see what is this gadget called JVA. It's as simple as this, a simple headset around your head. Just 1 minute, non-invasive test, which tells you subjectively if you any senior clinician also, they write only 14% of the time. But this JVA gives you information together from CBCT and MRI. This is as perfect as this. 87% is amazingly good sensitivity and specificity, right? So this JVA is such good gadget, a tool, which in 1 or 2 minutes you can diagnose if there's any problem with temporomandibular joint. How does that do? If there's no problem in the joint, everything is smooth. This is how the sinusoidal wave looks like. This is pure quantum physics, And if there's any problem, two surfaces having roughness, the sinusoidal wave changes. This is called quantum physics, okay? Pure quantum physics. Wherein every derangement in the joint has a signature waveform. And the moment you put JV and take, this is how the window shows up. We mark the vibrations purely on these numbers. We're going to check what is the problem. We have a JVA flowchart for that. This is for a beginner, for a learner. Whereas the waveform is for pure science, quantum physics. At that magnification, it will tell you what problem is there in the joint. As per Piper's classification, they put it into 4 groups, 1, 2, 3, 4, and we talk about the numerical values. And we believe in this quantum physics, signature waveform. That's how we diagnose, depending on these narrative and the numerical values. We diagnose what is the problem with the patient's temporomandibular joint, whether there's any internal derangement or it's a normal joint. This is a F50 waveform and a wavelet waveform to know the intensity of the forces in the temporomandibular joint. And when you have a joint tracker, you can do JVA with the joint tracker. That's how it looks. And depending on the numerical values, if it is less than 25%, it is anterior displacement of the disc from 30 to 60 anterior medial, 60 upwards, it is medial displacement of the disc. And coming to EMG, this is electromyography used from last. Oh, thanks to my demonstration in Dhaka Dental College, this is the picture. Intentionally, I put this. When I gave demo there in one of my visits there, they are the surface electrodes. After cleaning the skin thoroughly with the absolute alcohol, we put the surface electrodes. And why are we doing that? To quantify the rest. Maybe tonight you are going to sleep for 8 hours, tomorrow being a Sunday, or 10 hours, but are you relaxed? That can be quantified only by doing EMG, my dear friends. How? The ideal way for a resting EMG is less than 1.5 microvolts. Borderline up to 2. Muscles should be hyperactive if it is more than 2 microvolts. If I might have slept maybe for 10 hours, if my muscle activity is more than 2 microvolts, my body physiologically will not be rested. That can be only proved by electromyography. This is a channel EMG. You can see everything is resting except 2 of them are in the borderline. Look at this EMG of my patients. One more patient. Everything is hyperactive. You can do resting or functional EMG. You need to remember these 3 words: symmetry, synergy, and timing. Symmetry is same side, say temporalis muscles, or masseter, or digastric, or sternocleidomastoid. Synergy on the same side, temporalis, masseter, like that, and with a good timing. This is what it looks like. Beautiful timing, beautiful symmetry. Everything is in green. Green means, numerically you are resting properly. Okay. Symmetry is good, synergy is good, and timing is good. Coming to the other gadget, I am trying to rush through these gadgets so that I can show my cases in detail. Joint tracker is nothing but electroencephalography. It tracks the movement of the mandible. Whether it is range of movement or velocity or freeway space, you can sync it with JVA to understand the temporomandibular joint. And of course, today we are going to the next level. We are doing mastication analysis. First time in the world, thanks to Almighty, I have produced objectively measured mastication analysis, and we have published, me and John Radke. He is the inventor of all these gadgets, and objectively we have measured and published an article on mastication using this tool called joint tracker. This is how it looks like. It's literally about 750 grams, no weight at all. And this is how we place all these pillars. All these pillars are magnets, and we place one magnet in front of the uh, behind the lower lip and on the attached gingiva. And there's no interference like your intraoral or extraoral traces. Absolutely nothing else is there in the mouth. And we give the individual to eat soft food, hard food, and we are able to analyze today, my dear friends, thanks to the digital world. And this is range of movement. This is what you struggle, right, in prosthodontic department to get intraoral tracing. Look at that. Without any interference, without anything in the mouth, you get that. This is to do joint analysis with joint tracker. And all of us, we should understand these three words. Being in dental medicine, being a dental graduate, pitching, yaw, and roll. In the entire human body, musculoskeletal system, only joint is temporomandibular joint, which makes the one bone called mandible to go through these three words, my dear friends. Pitching, rolling, and yaw. Rest all the joints in the human body are linear joints, wherein the mandible with temporomandibular joint is a complex joint, and the mandible goes through all these three principles like aeronautical industry, aeroplane. A small video, I will not play this completely. This is available on Google to teach you to understand. This is basically for kindergarten children. What do we mean by pitching, rolling, and yaw? Right? So that's how he teaches what we mean by this. So that's what it is, my friends. Only mandible goes through these words. And with this data, what do we do? Let's go through few cases. This is one such case. A young kid, 19 years old, comes in after going through 5 years of orthodontics. In my office, we did another 8 months of orthodontics, took her through orthodontic surgery, and placed a couple of implants using bare bone management, a chunk of bone from her chin, and we loaded all those implants. This is how she came into my office. We did orthodontics, then increased her vertical height, and that's how we did. On all her natural teeth, Emax or lithium disilicate laminates and crowns, and screw retained crowns. I wanted this to go for her lifetime, not for my lifetime. So I took all my tools, biometric tools, T-scan and EMG. I measured. Look at the kind of force delivery, my dear friends. If I had left her, hope in this you see a beautiful smile, visually and photographically perfect occlusion. When I see with biometric tools, this is the kind of data I have. If I had left the girl for 6 months without without using this technology, probably I would have had a couple of crowns broken down, maybe 1 or 2 implants broken down, maybe prosthetic screws broken down, cracks in the crowns, XYZ. So I have the advantage of these tools. I checked, went and calibrated. Look at that. Look at the kind of muscle activity here. Post calibration, look at the muscle activity here, my dear friends. They become absolutely strong, but forces as normal. And excursive movements. Keep the picture in mind. Keep the picture in mind. Post calibration. Look at the way they become strong. We are measuring, my dear friends. Canine guided occlusion is a dictum, but with these tools, we have added the force and time dimension. Relative force against time. We are measuring. This should happen, canine guidance, in less than zero point 0.5 seconds. This is the right lateral. Look at the kind of activity in the muscles. And see now how strong they are. Beautiful canine guidance or anterior guidance, right? This is what I'm trying to talk about. This is a small video, pre-treatment and post-treatment multi-bite. Multi-bite is nothing but 2 or 3 bites in centric occlusion, my dear friends. This is pre-calibration and this is post-calibration. To see the beauty of it, we're able to measure. I know each tooth, how much force it is exerting at what time. This is a timeline, the gray rod. In the graph, the black line is the force line, and green and red, they represent left and right. Yeah, of course, in left and right laterals, we'll have 4 colors. Anterior 2 segments, left and right, posterior 2 segment, left and right. Look at that, so beautiful, isn't it? Yeah, let me rush through because of time factor. These are the left and right stills. 2.1 for disclusion time. That's what it is, my friends. Look at the hyperactivity of the muscles. After calibration, look at that. This is right lateral. Previous one was left one. Here is 3.05, what you see. Let's calibrate them and see how well they become. Before the calibration figures I want to show, I just want to talk to you about it. Let's see how much force this point is exerting at what time. Anybody can tell? There's no way. So go through these tools, about 4 or 5 corrections on each side. This is a kind of bow we use, pear-shaped bow. And this is the Dawson's dictum, right? Points at the dots at the back. Look at this post-calibration, beautiful symmetry, synergy, and timing, and dots at the back. That's what is all about, my dear friends. And of course, the disclusion time, and this is occluding time, and this is disclusion time. They turn green, that means it is absolutely normal, less than 0.3, less than 0.5. And of course, after each calibration, we use a diamond impregnated polishing disc to polish off all the teeth. One more case, a full mouth ear case. Look at this occlusal disease. Now, after going all through, the patient walked in and we did all the diagnostics and we fixed up all the 28 teeth with metal-free lithium disilicate or EMAX crowns. And this is before my work. Look at that hyperactivity, my dear friends. And look at the kind of, disclusion time is almost about 7 seconds. And look at this after calibration, after my work. Look at the muscle activity. Don't you think it is God's sent gift? Just because one of us said, oh, it is normal? No. We're objectively measuring here. This is right lateral. Look at that. And look at the time taken from C to D. That is the disclusion time. Look now, absolutely normal, 100% canine guided. Now canine has taken over in less than 0.5 seconds. Look at no activity there, my dear friends. And patient has a very good, comfortable, neuromuscularly peaceful situation. Of course, same patient's data. Here I want to talk in couple of slides about mastication. Every case of mine, full mouth rehab, I am measuring. This is called ACP about teeth. Same using the joint tracker and the EMG. And everything we talk in terms of values, numerical values. And this is about the muscles. Do you see the order? 1, 2, 3, 4 numbers here? They should be in order 1, 2, 3, 4, but it is 1, 3, 2, 4. What is this all about? Working side, masseter is 1, temporalis is 2, non-working side or balancing side temporalis is 3, and masseter is 4. So this order is not right, it is wrong. So I went, took my teeth scan, calibrated the teeth, and then went in and did the mastication analysis again. There comes the order. Lovely, isn't it? I've challenged myself. Not, I don't need to talk about this to my patient. I'm challenging myself. The work done by me, is it correct or not? That is the beauty, my dear friends. This is all about objectively measuring the mastication. Coming to one of the, we have published enough of these articles. You can log into ResearchGate and look for mine or Robert Kirstein or John Redkitt's articles. So this is one more case about temporomandibular dysfunction. The only problem this child had was a crossbite. Today she's a proud dentist and she's pursuing her post-graduation. Only her lateral incisors were in crossbite. And over a period of about 22 years of her growing as a child to an adult, she has developed asymmetry and she had a very bad migraine issues. We measured everything, and that was beginning of my career, probably about 10 years back with these tools. She had all this, was her whole data, very bad airway. I never bothered about it that time. So I took all the data, I went and did DTR. She had MRI data, she had CBCT data, very bad, multi-bite, went and calibrated, very bad excursive movements, went and calibrated. Disclosure time was absolutely, I brought it back to normal, but patient never had relief. Then I realized there's something more to it. Such cases where we asked them for CBCT and MRI, and I went and did joint tracker and JVA recording, and this is a FFT waveform. Of course, we have published about all these things. I did mastication analysis for her, 8-channel full-fledged EMG study for her. This is all about data. Friend, you wanted it? This is the kind of vertical height she needed. Believe me, my friends, almost about 12 millimeters. I gave her this plane, and now, being a prosthodontist, I didn't want to do 28 crowns for a fixed processes. So we took her through orthodontic treatment, and we are still, she's going through this part of the treatment. We have extruded her upper teeth down and lower teeth up. It would have been easy for me. 10 days I could have finished 28 teeth down the lane, right? This is what it is. Pre-treatment, look at the muscular hypertrophy and asymmetry, skeletal asymmetry. The moment I increased the vertical height, she almost became symmetrical. And look at this after 3 months. Absolutely doing well, right? This is the kind of decisions, diagnosis. We need to diagnose, even in a natural dentition. This guy came in from Dubai all the way just for 4 days. His problem was dizziness. What are a dental medicine graduate or a dentist can do? This guy is talking about dizziness. You want to send him to a physician? Dear friends, he has gone all around Europe. He came to me. He had all this data. And this is a pre-treatment multi-bite recording. Look at his muscle activity. I'll jump. Want of time. Look at this. Post-calibration. All forces are normal. Very good muscle activity with good symmetry, synergy, and timing. This is left lateral. Look at this black line. It keeps tapering down, right? Look at his muscle activity. Beginning is very strong. As he goes down, he cannot hold the teeth together because his muscles have discomfort or pain. Look at this post-calibration. Look at that black line. Absolutely beautiful U-shaped graph, right? And look at his muscle activity. It's instantaneous, my dear friends. This is purely because of the neurophysiology behind this science. The moment you clear the rodoms, you're able to drive smoothly. This is right lateral, same issue, same way. Look at that. Patient is not able to hold. It keeps tapering. Look at the force activity. Look at the muscle activity. And see after correction. They are beautiful, isn't it? Picture perfect. Beautiful U-shaped graph and beautiful muscle activity. This is what we are talking about. And jumping, this is pre and post, just to uh, show one of them is right lateral. Look at the forces delivered in the mouth. Can you and me go sit inside the mouth and see all this? It's impossible. Thanks to these engineers, we are able to see this today. Post calibration, the moment I brought it down, occluding time and discluding time to normalcy, patient was absolutely normal. Is doing fabulous. So this is about right lateral. Let me jump this video so that we see something more. Even removal prosthodontics. You can log into ResearchGate account of mine by name Prafulla Thumati. You will get all these articles. We can balance all the removal prosthetic work using T-scan. This is pre-treatment, pre-correction. 65% on the left, 35% on the right. The whole thing is on the front left segment, quadrant. And post-correction, look at that, so beautiful, isn't it? Front to back is CR-CO relation. There are two centric occlusion bites taken, red and blue you see. If you have taken three, there will be one more color. Left and right are so beautifully balanced. 49.9, 50.1. What else you need, my dear friends? We can balance all removable prosthetics with T-scan. Coming to implant occlusion, I just want to mention a point about it. I think we are running out of time. Any kind of implant work you do, we talk about time delay concept. What was taught to all of us? The moment I will give a pass here before I tell my statement. Time delay concept is a word we use. Maybe single implant, maybe multiple implant. You have another one or two cases to see in implants. If it is one or multiple implants, the implant supported processes, maybe crown or braid, should come in contact 30 to 40 milliseconds later with maximum force. So now you see already tooth number 8 has come in contact, 1/7 is the implant, and I'm playing the video now. Please watch. Look at that. It came into occlusion now, beautifully, isn't it? That is what is all about implant occlusion, my friends. Whether it is single implant or multiple implants. Now you see a case of multiple implants. Pictures of implant prosthetic work. Keep watching. The video is playing. Keep watching. This is a very bad force, already loaded. Implant is loaded, right? Now So the neighboring natural teeth should come in contact first and then the implant supported processes. That's what is all about time delay concept in implant prosthetic work. One more case. I'm going to show stills so that you can understand better. This is multiple teeth missing. I always opt for screw retained prosthetic work now instead of cement on prosthetic work. But still, badly loaded implant prosthetic work. Next still, after calibration. See, all the natural teeth are loaded now. Right? This is a crown. Implant means there will be eye next to it. Okay? Look at that. Now implant started getting loaded. See, all the implant prosthetic work got loaded. The last case I love to show you guys is frictional dentinal hypersensitivity. A lot of our human population, they complain about hypersensitivity, right? Maybe there are class 5 cavities or restorations or crown and bridge work then it is a different scenario. There are people whose teeth are absolutely virgin teeth, nothing is done on them. They complain of severe hypersensitivity. What all of us we do? Prescribe some hypersensitivity toothpaste, right? But my dear friends, neurophysiology demands there should not be friction between teeth. When you glide your teeth to left or right or front, it should happen in less than zero point 0.5 seconds. If it is more, that is a friction. Let's watch this case. This is an anesthetist, medical professional. I have given, this is a swish water test we call. Chilled water is given for her to swish around, and she talks about, look at that facial expression. Very bad hypersensitivity. I asked her to score her. Was scored 0 to 10. She said it is more than 10. Look at that. She said 10. So I go forward. This is after correction. This is the magic, my friends. In the next 2 slides, I'll show you. This is the beauty of using these advanced tools, T-scan, XYZ. And I ask her, score it. She says maybe 1 or 2. In Canada, she is staying. Only here I have a little bit, but it has come down drastically. And she is talking about around 2. What did I do, my dear friends? I did calibration using T-scan. This is a pre-treatment. I mean, this is electronic data. I cannot fool you. This is disclosure time for her, 1.4, 21st, 9th month, 2018 at 11:51. Post-treatment, same day, 11:59. If I go back, you see 11:51, 11:59. Our timings have become normal. This is a right lateral. Disclosure time is abnormal, 1.03. This is at 8 to 9 minutes later, absolutely normal. That's the beauty of this technology, my dear friends. This is all about occlusion. Unfortunately, we are not able to measure. Now we are able to measure. So if we can use this technology, we can help a lot of our fellow human beings, and God bless the humankind with the help from dental medicine graduates like you and me. This is about me. I am from Bangalore, India. Anytime you are most welcome to email me at this so that we can discuss about this subject. If anything more, you are most welcome to ask me questions or any more presentation. I hope I have not taken too much time, Aziz.
Thank you, Professor Prafulla, for your nice presentation. Now I like to invite questions from panelists or from listener and viewers. Okay, question?
I hope Khushida Tanzir madam liked our presentation.
Question from?
You remember me, madam?
Yes. I am very delighted
Dr. Khushida Tanzir.
that I am. Yes. Can you hear me?
Yes, madam.
Yes, everybody is hear you.
Thank you. I am very delighted that I am a panelist of this session. Thank you, Professor Thumati. I am glad to hear from you. And I have heard about you from Mustafa Sansar and in my journal, we published an article of you from City Dental College. I want to ask about the occlusal splint. During occlusal splint, do you adjust it with this scan
Yes, madam.
occlusal splint?
Yes, madam. Every dentist, right from America to Russia, they give splints. Only the splint, we provide orthotic.
Yes.
Only the orthotic which is calibrated using T-scan will help the patient, not otherwise.
Can we adjust traumatic muscular force by
T-scan
this
and
T-scan
EMG will help more.
with
T-scan and
the help of
EMG
EMG?
together.
Okay. Which type of traumatic muscular effect occurs
Madam,
here?
any kind of interference or trauma on the teeth will make the muscles to be hyperactive. That can be recognized. That can be recognized
Hyperactive
by
muscle.
using T-scan and EMG. So you can solve the problems.
Thank you very much.
Okay, Professor Prafulla,
Yes,
one
sir.
question from me. Professor
You
Prafulla,
have a question? You
can you
have a
hear me?
question?
One question from me.
Yes, sir.
Yeah, yes. Uh, the biometric tools or devices are, you told us in your presentation, T-scan,
Yeah.
EMG, JBA, electrotherapy, that is tracking. These are the
Yes.
devices or Bibles.
Yes, sir.
There are so many tools. There are so many, 4 to 5, and even 6 tools. All are biometric tools. Okay.
Yes, sir.
In
Yeah.
case of full mouth rehabilitation,
Yeah.
all tools can be used, or one or three, or all of that is all 6 tools will be used for full mouth rehabilitation. I want to uh, uh, know about the how many tools should be used in case of full mouth rehabilitation.
So there are basically 5 tools: T-scan, EMG, JVA, joint tracker, and TENS machine. Why do we use TENS? We want to record neurophysiological disposition. So after my last visit to Bangladesh, Dhaka, 1.5 years back, I had a referred patient from there, one medical doctor, and he came for about 1 week. Unfortunately, he was treated by full mouth rehab there. He had very bad issues. And after seeing this presentation, he was referred, thanks to Chaudhary Bhai, he was referred, and in 1 week I helped him using these tools. We read the whole thing. Probably in one of my presentation later, with the patient's consent, is a medical doctor. I will present this case to you people. These tools, it's not our experience. These tools gives us a guideline. This is the way to go. This is the road you should travel. So these are the tools you need to have. For any kind of TMD case or full mouth rehab we do. And T-scan is a master.
Okay, thank you. Thank you,
So
sir.
we need this T-scan. We have
T-scan
lack
is
of
for tooth.
knowledge and lack of
T,
trainers
that is
there.
EM, electromyogram. Dr. Sheila.
Yes, I want to say that we have. Yes,
You want to say something?
I want to add something.
Madam, I understood your question. Anytime any training is required, we are there, whether online or Personally, it's not a problem. I was there in Bagbendi University and Army headquarters, 2 days in each place. We are there to learn from each other anytime. It's not a problem.
Yes. I think more
Okay, Professor
support in it.
Sheila.
Yes, I want to
Yes,
add
sir.
something that this is actually a very important presentation here, and maybe we have this is one type of very important device we need in our general practice, that is in orthodontia and prosthodontics, and maybe this is uh, due to our lack of knowledge and lack of expertise here, and we need training here.
Yeah, probably from Indian Orthodontic Society, they asked me to write an invited article. I have written, and then one of the research article on post-orthodontic treatment (TMD) issues. About 50 cases we have published in Indian Orthodontic Society journal. And
Mhm.
nothing to do with our specialties, madam. Maybe I'm an prosthodontist, someone is an orthodontist, someone is a surgeon. But using the advanced technology, how best we can help our fellow human beings, our patients. That is the most critical point.
Yes,
Menas, you're sleeping.
Thank you.
thank you.
Now, Dr. Anupam Poddar.
I
Yes,
would
sir.
like
Dr. Anupam Poddar, now
you.
you ask
Yeah,
or some.
to say
thank you,
something.
Professor
Sure.
Prafulla Thumati sir, for your nice and informative presentation. I think it is the best one that all participants in our country enjoy this and fully enjoy. And this is the most important topics, the digitization of occlusion, and it is the vital topics in current situation. So I have a question. I am no not a question. I have a take measure for a case and discuss and want to know the accurate decision to about this case. The case is a patient uh, come to go to a doctor, Indian doctor, Calcutta doctor, with the complaint of uh, discoloration of maximum tooth with enamel hyperplasia and with severe attrition. But the doctor see the case and give decision for a full mouth rehab by zirconium crown. But
Oh,
nowadays the things occurs, the patient occlusal is not adjustment properly and one-sided by force maximum, but another side is free. But patient feel in joint pain and musculoskeletal pain. And what is the patient comes to Bangladesh and go to another my student and the need to he give measure. He want to measure the actual treatment, actual measure, actual treatment of this now condition, and he feel bothering and nothing. Always he feel bothering. What is the measure to take this, sir? Please giving me suggestion. And my student always asked to me, and what is the how it decided, how it this case is deal, and please suggestion, please, sir.
Anupam, 2 points. Zirconia is not at all a good material like PFM crowns. It's not a material to be put into the mouth. Zirconia is a very bad material unless until we are making the long span bridge. But with advanced technology, Mother Nature has given us single teeth. If any tooth is missing, time has come, we should not advise bridge work. I'm dreaming before I die, the bridge work is out of our curriculum. If a tooth is missing, we should place an implant and give a single crop. That is one thing. Second thing, zirconia should be used only if you are making a long span bridge. But otherwise, God bless material is lithium disilicate, so-called Emax crowns. You should always use Emax material. If you're using dental gold, it is fine. The next best material is Emax. And in Bangladesh today, there are 2 or 3 T-scan machines. You can take the patient there, measure, use Emax material and mix single crowns. Patient will be much better. Personal
Yes,
work.
sir. Yes, sir.
Thank you, sir.
That's what it is. Yes, Aziz, sir.
Thank you.
I am
Thank you.
out of contact, so I don't understand, sir. I don't.
Waiting to visit to that.
What is the matter, sir?
Dr. Anupam, any more? Any more question from Anupam?
Yes.
No, I think
No more
Dr.
question.
Mehanas,
No more question.
I think Dr. Mehanas is want to say something. Dr. Mehanas,
Sir, I would like to request.
I think
Sir, I would like to request Dr. Mosharraf Hossain Khondokar, sir, to say something about the section, please.
Okay, thank you.
Something
Okay,
about the
thank you, Dr. Minas, Dr. Imad. I like to thank you to arrange a beautiful, such a nice program on behalf of Bangladesh Dental School Board. First of all, I like to give my regards to the chairperson of the program, Professor A.K. Azizul Haque, ex-professor and department head of Prosthodontics, Dhaka Dental College. He is also my teacher and now working as the president of Bangladesh Prosthodontics Society. And he's also very expert in public health specialist in Bangladesh. We are enjoying the program. Here we are happy to get Professor Dr. Khushida Tanzir. She is our very dear and near in curriculum and extracurriculum activities. She is very student friendly and running her department in the City Dental College very nicely. And we are always happy and we are proud of her. Here, I am very happy to get Anupam, Dr. Anupam Badar, associate professor and Department of Periodontology. He is also a great prosthodontist, and I like to give him thanks for his tremendous and active participation in COVID-19 regarding his contribution on awareness, prevention, and he has made so many, I can tell the series of episodes covering the guidelines and what should do, what should not, cover everything regarding the COVID-19 situation in this pandemic. Congratulations, Dr. Anupam, for your nice role in the pandemic situation. Here we are proud to have our prosthodontist, Dr. Riyad Mahmood. He is a very talented prosthodontist. I think all of present are the renowned prosthodontists. Thank you very much, our renowned speaker, Dr. Prafulla Thumati, Professor, for his nice, great presentation. Actually, I know you from papers, though physically I am new, but I have a great respect and honor to you because you are a great prosthodontist as well as implantologist, and you are very much professional regarding your patient. And I know from the books that your patients are very happy with your friendliness, explanation of health status, and also they are very satisfied with the treatment. They are happy giving very money and also time because you treat them very cordially. So that today, what we got, I think this very nice topic, that is digitalization of occlusion. There are variations in concept of occlusion. Almost every specialty of dentistry, all department. Being I am also endodontist and I'm practicing operative dentistry, I think the occlusion should be in static and also dynamic condition. So therefore the dental surgeon should must understand the precise details of the occlusion. One thing to elaborate everything, that occlusion is not the I think very easy, though in worldwide digitalization is part and parcel of prosthodontics, but I think yet the what I say, I understand that diagnosis and the treating of occlusal error never been easy, because it needs some special technology. And what we got, we got that the managing here, the managing or adjusting occlusion is some cases is puzzling or frustrating for both patient and doctors also. The most tool we use treating occlusion is articulating paper. It has remained unchanged over a century and dentistry around the world. But you show the modern technology, that is objective measurement, that is T-scan or MAT scan. Yes, actually we need, because if we don't understand the technology, we are under dark. That's why I think very clearly that occlusion is probably the biggest loss of production in dentistry, because that are given away and patient and dentist don't understand this thing. So that I like to thank you giving the light and understanding about the computer assisted occlusal diagnosis, knowing the intensity, direction, sequence and pattern of force in any occlusion that creates numerous income producing opportunities that are currently ignored by the majority of general practices. So the adopting this digital occlusion practices provides their value and generates income. Anyway, again, I like to congratulate you for giving us, just I like to finish giving one thing, what we do, like pain in TM joint. We usually do CT scan, CBCT or MRI, but we do not go to the objective measurement like T scan or joint and vibrography or electromyography. So you showed us, you give us the way. And as a director of dental education, you know, I am working as a director of dental education in our Director General of Health Services. I like to make and program, hands-on program. And Dr. Anupam Badar know, and I shared and discussed with him. Yes, really, I am very much charmed about your lecture, about your this session. In near future, we will invite you on behalf of our government. So Dr. Anupam and our chairman, Prof. Azizul, will with our task. So I like to thank all the dentists, not only prosthodontics, the general practice also need this occlusion, because occlusion correction is very necessary. So I hope we will meet together. And again, congratulations you and also the other panelists and the dental one for arranging this this session. Thank you, everybody.
Sir, dentistry is nothing without occlusion. Not prosthodontics, not any subject. Dentistry is zero without occlusion understanding.
Yes, I think so.
So good night, all of you. I hope I delayed you for your dinner. Here my family is waiting to have dinner. God bless you all.
Yes,
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 sir.
my regards to you. My regards to you.
Professor Prafulla,
Yes, sir.
Professor, Professor Prafulla,
Yes, sir.
Dr. Khondokar Mosharraf Musa, Dr. Khondokar Mosharraf Musa, now he is working in the DGHS, Director General of Health Services, under the
Yes, sir.
Ministry of
Dear Prafulla sir.
Ministry of
Anupam.
Yes, sir.
Okay, yes.
Professor Dr. Mosharraf Hossain Khondokar is the Director Dental Education of DGHS of Bangladesh. Yeah,
Give my
yeah.
regards.
He maintained the all dental education in Bangladesh, and all types of local and foreign training is maintained by him. So I think the next time we go to arrange a training program, foreign training program with the help of Director Dental Education Sir Mosharraf Hossain Khondokar sir. And if he give opportunity to us to arrange the program in Dhaka Dental College, then I would like to invite you as a trainer for our local and non-local trainer, non-local participant, and they enjoy your lecture and they enjoy your hands-on course, and probably
We
the
officially invite
professor,
you. We officially
I
invite you.
would like to thanks to Professor sir for your nice and informative presentation. And I think you are the well-known T-scan specialist, and everybody know him in Bangladesh. I hope you will do better service to us, and in future you can you come here and also give training program to to us. Thank you, sir, for you give me
We will do
time
that.
to us,
Okay,
and it is
We
yes,
will
sir.
okay,
do
Dr.
that.
Anupam Poddar.
And
Okay,
I
Dr. Anupam Poddar. Dr. Khushida Tanzir Sheila, last,
Yes.
in the last,
yes,
you
sir.
say some speech.
Okay. Thank you very much. This is a nice presentation, and it is helpful. Actually, very helpful for our general practice, and because this occlusion will create various problems. So thank you very much. Your family waiting for you maybe for dinner. Thank you very much and good night.
Good night to all of you. God bless
Sir,
all.
one thing,
Be safe in this
Prafulla sir,
pandemic
one thing.
time. Hanji Aziz bhai.
Okay, Prafulla sir, one thing. Uh, your presentation is very, I want to say it's hard digitalized. So, uh, if any general dentist can use this type of tools for the management of orofacial pain and other processes.
Sir, every
My
dentist
question, my
like
last
having
question.
mouth, every dentist like having mouth mirror and probe should have a T-scan. Occlusion is not just for stomatognathing system, it is for the entire musculoskeletal system. Only tool currently in the world with which we can analyze is T-scan. So every BDS graduate, like having a mouth mirror and probe, should have this tool. So all of you, God bless, Shubhrat, safe, be safe this pandemic times. I take your leave. Good night. Good night, all
Just
of
I
you.
arise this
Good
question
night.
as
Sir,
I arise this question. Why? Because some professionals realizing, some
yes, sir.
professionals asking, some
Every
professionals are
BDS,
observing. This is for orthodontists. This is for orthodontists. So this is the I arise this question. Every professional can use this type of biometric
Yes.
tools for
Yes, sir.
management of orofacial pain and for a successful prosthesis. Okay,
Yes, sir.
thank you. So another one, uh, uh, Dr. Khondokar Musa, Director Dental. He is now working in the DGHS. The Furkan Siddiqui was working. He worked in the DGHS. Now he is
Sir,
in Jahangir
sir,
University. He retired from.
please give
Yeah,
my regards to
Furkan.
Furkan Siddiqui. Please give my regards to
Now
Furkan
working in
Siddiqui.
the. I try my best. Dr. Musa, our previous one, Musa is now working in DGHS, that is Director General Health Service, as a Director Dental Health Education. Now he is engaged about the training and other foreign training, local training, every type of training in the institutions of medical and dental institutes of Bangladesh. So, very recently, we are arranging some foreign training, foreign training uh, in Dhaka Dental College. And this will be arranged and by the DGHS. And Mosharraf Musa was on the focal person, I think.